Okay, so yesterday we talked about blood, body fluids, and respiratory specimens. All right, so our specimen collection guidelines. Do you remember what I wanted you to know off of this slide? Collect from active disease sites. Good. You want to avoid contamination, use sterile containers, accurately label, and make sure that you're taking your precautions and take into account any travel history that your patients may have. All right? And so, if you are collecting a virus, when do you want to collect them? Correct. And for bacteria, before or after antibiotics? Before. Ooh. Proper transport. How do we transport the stools? In a Harry Blair container, transport container. All right, our critical finds. There was a couple of critical finds, but this is the slide I really wanted you all to look at. So when doing your rapid strep test in adults, if it's negative, we're good to go, right? But if you do a rapid strep on a pediatric, less than 16, what is the follow-up test that you have to run? A culture. Good. All right, so in blood, if you suspect somebody that has endocarditis, what are your next steps? Yeah, if it's endocarditis, and if it's, hold on, I'm jacking this thing up already, y'all. All right, so you have a patient, she has symptoms of sepsis, including high fever and tachycardia. You suspect endocarditis, but the blood culture showed no growth after 24 hours. What are your next steps?
212.
Two more sets. If the cultures remain negative after 24 to 48 hours, or if endocarditis is suspected, okay? All right, here is that breakdown again. All right, and I put the actual answers from yesterday. We're going back and forth, okay? So that check on learning slide. So if you receive a lab report on 2 simulated patients, 1 out of 8 blood culture bottles for each patient is positive for coagulase negative Staph aureus. Is it a contaminant or a real infection? So the first patient has no central line. So if we go back, right, and we look at the 1 blood culture, right, and that first patient had 2 out of the 3 SIRS. Had no central line, but there was 1 positive blood culture, and they had 2 or less SIRS symptoms. So that first patient, was probably a contaminant, okay? But the second patient does have a central line, so if you go back and look at that and go through your algorithm, they have 2 symptoms, has a catheter, has 1 positive culture, but has less than 2, then it's a positive, okay? All right, so I have a couple, maybe, I probably only put 1 question, but just make sure, I'll make sure to put this on the test for you, and then you all determine whether it's a contaminant or if it's an actual sepsis and needs to be treated, okay? All right, so I think we peeled this, especially from block 1, but you understand the difference between viral infections and bacterial. What are the differences between the 2? Neutrophils are in the bacteria, lymphocytes are in the viral vector. All right, and what kind of crystals are found in gout?
Uric acid.
Monosodium urate, yeah, and pseudogout? All right, so in tissue biopsies, when you have deep sampling, you want to use what tool? Punch tool, and then in your superficials, you want to use scalpels and razor blades. Okay, and we already talked about this, right? Strep, if it's negative in an adult, don't treat. If it's negative in a kid, you got to follow up with that culture. Okay, now, we went on to number microbiology 2, which we talked about your genital, skin, soft tissue infections, right? So we did a lot of this in part 1 with our point of care, but just know your wet mount, right? You're looking for trichomonas, flu cells, fungal elements. Your KOH prep, same thing, fungal elements. All right, so the only thing that's added that we didn't talk about before was just that pH. So if you have a vaginal pH of 4 to 5, know that may be a yeast infection. If it's greater than 4.5, think BV, and greater than or equal to 6.6, think trichomonas. All right, so if you have a patient that has suspected pyelonephritis, what kind of urinalysis sample are you going to collect from them? Catheter or Foley. Okay, that's all I need for you to know off this slide. All right, and so you all already know about UTIs. We talked about UTIs. The only thing that we're adding on this now is that we're talking about the bacterial growth for microbes. So if you see greater than 100,000 CFUs per mLs, and it's of a single organism, that is also indicative of a UTI, along with the white blood cells, along with the bacteria, and all the other clinical symptoms that I'm going to provide for you all. Okay, that is there. And then here, I didn't really talk about it too much. I breezed through it the other day, but uncomplicated UTI versus complicated UTI. The only thing that I want y'all to catch from this is that if somebody is healthy and they have a UTI, it's uncomplicated. If they have an underlying condition, it's complicated. That's really it. Okay. And then, why did I put this slide on here? Okay, yes. So, HSV, herpes. So if I use the term giant multinucleated cells, you think herpes. If I say there's a school of fish, I found a school of fish under a microscope, think herpes, okay? And the stain that is used to detect herpes is, what is that up there with the TZ? Zinc smear, okay? So zinc smear, giant multinucleated cells, school of fish, see any of those terms, think herpes. Right? And then here, this is just saying, when you do your skin scrapings and you do your KOH prep, make sure that when you see a scale on your patient's skin, that you're taking it from the border of the lesion. That's like half the test right there. So, if you suspect you have a kid, they got some scales going on in their head, you're like, oh, this looks like some fungal, I'm gonna put that wood lamp up there. And it fluoresces blue-green. What is that telling you? They got Tinea capitis or some type of scalp fungus. Okay? I think that's it for the review. Okay. All right, so let's move on to our next lecture. Any questions? I'm sure y'all have questions because y'all got this. Okay. All right, so block read. So now we're going to go more into serology and GI. All right, so serology, we're thinking antibodies, antigens, right, and GI tract stuff. So I know y'all had infectious disease already, right, as a freshman. You've had microbiology as a freshman. So I'm not going to, we don't have to be like, this, the GI tract, I ain't doing it. Y'all know I'm not doing that, right? So I'm going to just tell you the disease states and what tests you need to run for those diseases. Okay? So TLOs, actions, conditions, and standards, and ELOs. Right? We're going to talk about immune responses, a little bit of titers. We're going to talk about acute hepatitis panels, and diagnostic values for stool specimens. All right? This is your reference. Comes from chapter 57. All right, our clinical introduction scenario. A 32-year-old male returns from travel to a tropical region with 6 days of watery diarrhea, abdominal cramps, and fatigue. He reports consuming local food and untreated water. Initial stool PCR reveals Giardia lamblia, and an ova and parasite exam confirms trophozoites. A rapid antigen test supports the diagnosis. Prompt antimicrobial therapy is initiated, resolving the infection and minimizing risks to others. So pretty much we're going to be talking about PCR and OMP, really. Okay. So these are just factors that influences the GI tract. I'm sure you all got this. This was actually the most common non-combative disease during OIF and OEF. So people, even though they were getting shot by bullets and getting their arms and legs cut off, it was actually these daggone parasites that was actually taking us out. How about that? So some common GI cases. Seen these. So gastroesophageal reflux or GERD, chronic diarrhea, gastroenteritis, ulcers or H. pylori, and hemorrhoids. Okay, we'll talk a little bit about these and what I need for you all to know specifically. Okay, So a lot of the challenges when diagnosing these infections, it can be kind of complex. It's hard to differentiate normal flora from the actual pathogen itself. And so because of that, there'll be multiple tests that need to be run. There's really not one particular test that's going to really identify any of these pathogens. You're going to have a series of batteries of tests to determine the appropriate diagnosis and appropriate antibiotic therapies. All right, so this is the money slide. So of course, this is very important. You will see all of these terms on your exam. All right, and we're going to go a little further into them. We're going to talk about PCR today, fecal fat, which you see in malabsorption, fecal leukocytes. This is when if we see fecal leukocytes, from there we have to identify what's an inflammatory versus inflammatory cause. Then you have lactoferrin, which is the protein that's within those white blood cells that we can possibly see in the stool. We're also going to talk about stool pH. We're going to talk about the macroscopic version of the stool, so that's just the visual, the consistency, what it looks like, colors, things like that. We'll go into cultures, OMPs, and toxin assays, and a little bit of serology. All right, so what is a PCR and why do we run PCRs? Okay, so PCR stands for polymerase chain reaction. This quickly IDs pathogens in the stools, right? This is what we see in our microbiology labs. A lot of the PCRs can be run within an hour or in a couple of hours. And basically all it's doing is we take that sample, we place it on the machine, it'll start unwinding those DNA sequences. Once the machine is able to identify the pathogen itself, it'll prime it, bind it, and then what it ends up doing is that it'll cycle for about 30 to 50 cycles until it's large enough for the machine to actually, it'll amplify it, and then the machine is able to identify whether it's a bacteria, a virus, or a parasite. We like PCR testing. It's very quick. You get your answers in a relatively good time, and not in a couple days, hours, things like that. So here's some lab tests for GI tests. This is FYI. I'm sure you've seen this list before. All right, so it's just breaking down bacteria, the big threes, which is the Campylobacter, Salmonella, Shigella. Then you have your little threes, which is Yersinia, Vibrio, and E. coli, and then your toxins, which is C. diff. So fecal fat testing, like I said, this is seen in chronic diarrhea and steroidea, okay? Anytime we see an elevated fecal fat, this is indicative of an impaired digestion or some type of malabsorption is going on. So there's two methods for fecal fats. You have qualitative, that's pretty much saying yes, that it's either in there or it's not in there. And then you have the quantitative version, which we do not necessarily see because personally, I don't want 72 hours worth of stool. I don't need all of that, but some people need it. So 24 to 72 hours of stool are collected for accurate fat measure. It's not very common. All right, so here are some lab tests. So please make sure you're highlighting this slide because you will need to be able to differentiate fecal leukocytes versus the lactoferrin in GI infections, okay? So in fecal leukocytes, we're looking at this under the microscope. Under the microscope, we're seeing intact white blood cells, okay? We use a methylene blue or trichrome stain, and this helps us distinguish that non-inflammatory diarrhea from inflammatory diarrhea, okay? So if we see an increase of white blood cells, we think inflammatory. We see this in IBD, Shigella, Salmonella, and E. coli. And this lets us know that there's an acute infection going on. So increased white blood cells, inflammatory, acute infection. Now on the other side, you have lactoferrin, all right? And these are the proteins that are found within those white blood cells. And we run this on what's called an ELISA or immunoassay machine, all right? This actually monitors the severity of the inflammation. Anytime we see an increase of lactoferrin, we're thinking this is more chronic. So they already have something going on. If we see an increase of lactoferrin, we know that this disease is getting worse, okay? So what I want y'all to understand between the two, fecal leukocyte, think acute inflammatory diarrhea, lactoferrin, chronic inflammation monitoring, okay? If you got that down, you're gonna do well on the test. All right, So stool pH, make sure you're highlighting this as well. I'm gonna have a couple of questions. I'm gonna give you clinical scenarios, but what's gonna distinguish the different types of disease states is gonna be their pH, okay? So if you have a pH of less than 5.5, think carbohydrate malabsorption. A stool pH of 6 thinks transient diarrhea or SIBO, which is that small intestinal bacterial overgrowth. A pH of greater than 7, secretory diarrhea, and then a pH of greater than 7.9, think gut microbiota. Think colon cancer, okay? Think colon cancer, okay? So that clinical scenario looks very familiar, so I might use that because I like it. All right. Here is another slide that I will not be using, but it's important for you all because you see that Bristol stool chart. That's actually used a lot in GI clinics, especially with children. If they have stuff going on, they're unable to describe their stools. A lot of times they'll just have the kids like, okay, so what does it look like? And they'll point to it. And if you know what it looks like, then it'll help you diagnose your patients. So if you see if there's fresh blood in the stool, this may be indicative of an acute lower GI bleed. Bloody mucus, some type of ulceration, black and tarry, occult blood, pale-colored obstructive jaundice. And do you remember what the bilirubins are supposed to look like? And those liver panels, do y'all remember? Increased bilirubins, correct. And then green, says spinach, I don't know what's up with that. Antibiotic use, and then if it's nutty or corny, you know that is normal, okay? All right, stool cultures. Important slide, okay? Important, very important slide. We got a couple of stool culture questions on the test. So why? We identify bacterial pathogens in bloody diarrhea or diarrhea that's greater than 3 days with travel, okay? 3 days with travel, so make sure you got that down. And this is, target the organs that are primarily gram-negative enteric pathogens, okay? So gram-positive exceptions would be C. diff, Enterococcus, S. aureus, and Listeria. And that's another great clinical scenario as well, so I like that. Okay, so remember I said big threes and little threes? So big threes are your Salmonella, Shigella, and Campylobacter. The Petri dishes that we use a lot of sheep blood agar, McConkey agar, and Campylobacter agar, and that's just that dish media that we use. We take that stool, get a little piece of it, place it on the dish, streak the plate, put it in an incubator for 24 to 72 hours, and see what grows from it. Now, extended stool, the little three, Vibrio, Yersinia, and E. coli, they also take this same Petri dish, but they need more extended, what we call extended media. So on top of the 4 blood agars that we use for the big three, the little three needs these additional agars, which is the TCBS, CIN, and sorbitol. So ONP, ova, and parasite exams. So this is another thing that's highlighted in red, which means it's important. We suspect a parasitic infection with persistent diarrhea of greater than 7 days and foreign travel. So if you have those two, you want to run an ONP. Right? Acute diarrhea episodes are mainly caused by viruses or bacteria, and then your chronic diarrhea suggests a parasitic infection. So for ONPs, make sure you are gathering 3 stool samples, collected on 3 separate days and times. These are the top 3 parasitic infections in the U.S. Giardia, Cryptosporidium, and Amoeba histolytica. Okay, so you may see Amoeba histolytica. That's what you're going to see on the test. All right, so lab tests for GI cases, toxin assays. When will we run these? So if your patient's been hospitalized or recently taking antibiotics with greater than 3 or more loose stools per day for at least 2 days, and there is blood or mucus in the stool. So that is the key determining factors if you're not sure what test to run, okay? Antibiotics with greater than 3 loose stools per day for at least 2 days, or there is blood or mucus in the stool. All right, Toxin assays enhance virulence, and they provide rapid ID identification for us, and that's why we like toxin assays in the lab. So our most common toxin assay is C. diff. Okay, this is for those inpatients. They've been inpatients for greater than 3 days, or those that are on continual antimicrobial treatment. Okay, I'm going to talk about it, even though I won't test you on it. But Shiga toxin is a common, and then uncommon is botulinum and staph enterococcus B and B cereus. But C. diff is what I really want you to know. That's the most common. And so serological testing, this is just going straight into serological testing. So some pathogens are difficult or impossible to culture, so then we have to look at antigens and antibodies to test these, okay? So we're gonna, with these, you can detect either an immune response or identify the antigen. And these are also very quick as well, and we get you your answer in a relatively prompt time. All right, so serological testing in GI cases. All right, you have H. pylori that detects the IgG antibodies antigen. You have C. diff, rotavirus, Giardia lamblia, and Entamoeba histolytica. So the one that's highlighted is the one that's important. Look for that toxin AB enzyme and amino acid EIA. All right, so money slide. So this is a very important slide. How are y'all feeling about antigens and antibodies? I know you probably got it in pathology, right? Did y'all talk about it a little bit? Okay. So just take what you learned in pathology. We're just going to add it, right? What I'm going to specifically be testing you on will be on hepatitis B. Okay. So this middle one down here. So I want you to understand how a patient will present if they've already been vaccinated versus if they're in a current infection. Okay, so if somebody has a current HBV infection, their hepatitis B surface antigen will be positive, their hepatitis B antibody will be negative, and their core antibody B will be positive. They're currently contagious. If they're vaccinated, their hepatitis surface antigen will be negative, their hepatitis B antibody will be positive, and their core antibody will be negative. Okay. So just make sure you get these down. All right, so immunological testing. We do have a couple of rapid parasite panels that you all could possibly use. But a lot of times, even with a rapid test, even if it's positive, you still want to send the remaining specimen to a level 4 lab, okay? So in rapid panels, we test things like streptococcus, Giardia, Rhiptospira, and Entamoeba histolytica can also be rapid. You also have your H. pylori, that is also a rapid test as well. And then there's fluorescent antibodies that we will do. Okay, the fluorescent antibodies, and then, looking up PCR testing. So this is our ELOs. Make sure you highlight all the stuff that I told you to know. I know I went through that really fast. And do we have any questions before we go on to the next one? Do y'all want to breeze on through? Do y'all need breaks for 20 minutes? We're going to go to the next one. Okay. I didn't realize I went through that fast. But I'm not, I'm always going to tell you what you need to know. Because I hate to, have y'all see the same stuff over and over. All right, so this is going to be, I think y'all had infectious diseases already, so we're not going to get too much on the different types of diseases. We're just the disease states that are important to us, how we test them. That is what I want you all to know today, okay? So infections of global importance. TLOs, ELOs. So we're going to be talking about TB, HIV, malaria, and a little bit of biothreats. It comes from chapters 22, 57 through 59. All right. Clinical introduction scenario. A 36-year-old male presents with fever, weight loss, night sweats, and a persistent cough after returning from extended travel in East Africa. Chest x-ray shows upper lobe infiltrates and 3 early morning sputum samples confirmed with acid-fast bacilli. HIV testing is also positive with a CD4 count of 175. Due to the co-infection with TB and HIV, treatment is promptly initiated along with airborne precautions. So this is just showing the relevance, why it's important. Of course, we're military, that means they can send us all over the world. So these, you know, we may see these things, right? So you may have your patients that may have had recent travel, they have fever and weight loss, consider malaria or some type of TB testing. All right, so this is an important slide. Make sure you get this down. I really need for you all to know the difference between a latent TB versus an active TB, okay? So in latent TB, this is gonna be asymptomatic, it's non-contagious. A lot of times, your patients will not have any symptoms and their chest x-rays are normal. And their sputums may come back negative. As opposed to those that are in active TB, they're symptomatic, they are contagious. In active TB, you will see the symptoms of cough for going on for more than 3 weeks, fever, weight loss, and night sweats. Their chest x-rays may come up normal, but their sputums and their cultures will be positive, okay? So now the difference between those two. And also in the latent TB, even though you may not see anything at the moment, it could progress to active TB within 2 years. Here's another important slide, and this is just showing the difference between that TB skin test versus IGRA. I know when I first came in the military, and being in the hospital, I used to get a TB test every year. They have since gotten away from that, moved away from that, which is good because a lot of people were getting up with those false positives all the time. Because if you were already vaccinated, the TB could actually show that you looked like you were positive when you really weren't. So now, for us as healthcare, well, I'm not a provider, you all are healthcare providers, but for us that work in the hospitals, and we need to be tested for TB, now the better test is the IGRA, okay? And that's because it's not affected by the vaccine, you don't get those false positives. So that's really what I really want y'all to get, the difference between the two, okay? All right. Active TB testing. This requires 3 sputum specimens within 24 hours. All right? Anybody in active TB also needs a nucleic acid amplification test. All right. So what are the two? The first one are how many specimens? Sputum specimens?
3.
Within 24 hours. And then that last one, nucleic acid amplification test, okay? You got that down? You'll be all right. Active TB testing. So positive AFB smear and a culture confirms active TB. This also requires a chest x-ray. All right, and then when you have your susceptibility results, we'll talk about that next week. This will help guide your treatment and indicate possible multi-drug resistant TB. Money slide, so you know this is an important slide. Okay, and so remember, I just need y'all to know latent versus active, and then understand the difference between that TB skin test versus that IGRA test. Okay, so this is just presented in a different way. It's easier for you to read that way. All right, now we're moving on to HIV. All right, so HIV. Let's see, I think we have 1, 2, 3. All right, so four things you need to consider in HIV patient management. The first one is your CD4 count. So a normal CD4 count is between 500 to 1,500 cells per milliliter, okay? If you have a patient that has an immune status and is at risk for AIDS illness, if they have a CD4 count of greater than 200, they are at low risk and they have an intact immune response, okay? If the cells are less than 200, this is the clinical definition of AIDS. So less than 200 for CD4, clinical definition of AIDS. All right? And then if there's less than 50 on their CD4, you may consider advanced HIV and they're at high risk for high opportunistic infections. And why do you think that is? with a low CD4 count, that's telling you what?
34.
Yeah, your immunity's low, right? And so when their immunity's low, a cold can take them out, right? An upper respiratory infection can take them out, okay? So if you already have a patient that has AIDS-related illness, a low CD4, you may have to run those additional panels, okay? All right, so here are the other three. You got viral load, HIV resistant testing, CDC, and metabolic count. So viral load means the amount of HIV virus in the blood. This assesses the antiretroviral therapy and their response, right? HIV resistant testing is mutations in HIV that may make it resistant to specific medications. So it's important that we're going over genotyping and phenotyping, and this also will determine your antiretroviral therapy response as well. And then lastly, we've got CDC and metabolic panels. And why do you think we need to run CDCs and metabolic panels on those with HIV? Say it again? Correct, absolutely right. Yeah, so you're looking at your drug treatments, right? You're making sure you're looking at their livers, their kidneys. Yeah, see, I got it, common sense, right? I got this. And check for diabetes risk as well. All right, so regular screening testing for those that are HIV, their CD4 counts, as long as it's, and if it's less than 50, of course, you got to do those other tests, right? You got to test for viral hepatitis, STIs, whether that's bacterial, viral, and cancers, and TB screening. So this is just a list of what I just said. If you just want it all on one slide, these are all the different tests during HIV patient management, okay? All right, now we're moving on to malaria. All right, malaria, I have seen this so many times, this picture up here, but malaria has that global impact, right? Affects over a third of the world's population. Some of the most common malarias are Plasmodium species, the P. vivax, and the P. falciparum, okay? We have the 3 life stages, we're not going over that. And our diagnostic challenges are the erythrocytic life cycle, which we don't need to go over. But we do need to go over this, okay? So P. falciparum is the most deadly, P. vivax is the most common, and P. malaria you see within 72 hours. So in diagnosing, you got to take into account their travel history and their fever periodicity. Okay, so here's a breakdown. So what I need for you all to know with P. falciparum, under the microscope, the red blood cells will look normal, but they will have what's called these Mayer-Clef's rings on the RBCs. If we see Mayer-Clef's rings, we know that it's going to be P. falciparum. Okay. P. vivax and P. ovale will have Schaffner's dots on the red blood cells. Okay, this is the most common, P. vivax, P. ovale. P. falciparum, the most deadly. And then P. malaria, those red blood cells will be slightly enlarged. We will see some trophozoites, and it'll be like band-like structures. That clinical scenario, I think I just caught. I like the clinical scenario, okay? You all should like it too. Okay, and so this is just FYI. You will not see this under the microscope. This is what our laboratorians will see, and this is how we determine the difference between two. And it's really not, it's not a good picture. It's very blurry and small, but we are usually, when we're looking at this, we're like all up in the cells. We're looking at everything and making sure that we're distinguishing and identifying the correct type of malaria. Okay, so this is important for you all. Our gold standard for identifying malaria would be blood smears. We have one, a thick smear and a thin smear, okay? Our thick smear will reveal parasites in the red blood cells, and our thin smears will be used to ID the actual species itself, okay? That's really what I need for y'all to know. So thick reveals what?
Red blood cells.
Parasites. Thin smears are for, yes. Boom, boom, boom. All right. All right, so interpretation challenges. Blood film interpretation. These are challenging for inexperienced microscopic, which has nothing to do with y'all, but we do use rapid antigen testing for confirmation. So even if we see this under the microscope, we still will run some additional tests before officially calling it malaria, right? For negative results, if the initial result is negative, when we do that follow-up test, then we will repeat that testing every 12 hours for 24 hours if malaria is still suspected. All right, so this is point of care testing, which is very applicable to you all. All right, and that's an example of what one looks like. And yes, when I was deployed, we did use these for a little bit, but of course, we always followed up. We still ran blood, we still sent it back to microbiology for confirmation testing. But if you just need that initial response, positive, negative, this is good, okay? It'll help triage, and it'll help for you all if you need to go ahead and treat your patients. So I'm not gonna have any pictures like this, but just know, point of care is gonna give you that quick yes or no. All right, clinical considerations, monitor response to therapy. All right, now we're moving on to viral hepatitis. Remember we talked about that liver, right? Liver inflammation, jaundice, dark urine, pale, stools, elevated ALT and ASTs. Okay, so just know that hepatitis A is fecal oral, hepatitis B is bloodborne, sexual, hepatitis C is bloodborne as well, hepatitis D is acquired, and hepatitis E is acute, self-limiting, except in pregnancy. I will not test you on that, but I will test you on these. Okay, so this is the same slide, okay? Just make sure you're knowing when someone is vaccinated, what that would look like versus somebody who's in a current or they're actually contagious. And also, I will let you know, to guide you to make sure that you get that right answer, I will let you know that their elevated liver function tests, their ALTs and their ASTs will be elevated, okay? As long as you got this, you're gonna be good. There's a couple questions about that. So hepatitis D and E, I will not test you on it, but I will talk about it very briefly. Hepatitis D, acute and chronic, a co-infection with hepatitis B. Hepatitis D antibody confirms infection, and the RNA positive confirms an active viral replication. Hepatitis E is self-limiting, and it has a high mortality risk during pregnancy. All right, vaccinations are available for hepatitis A virus and hepatitis A and hepatitis B. And there is no vaccine for hepatitis B. So hepatitis A vaccine is key for deployed personnel, and hepatitis B is for acute and chronic infection. So for anybody who has deployed or haven't deployed yet, it's like you're going right back through basic training when they hit you with all those vaccines. It's ridiculous, but it is what it is. We gotta protect ourselves, right? So deployed personnel receives Hep A and B vaccination to reduce infection risk. All right, so this is pretty much the same thing, just in a chart form. If it's easier for you to read that way, remember, just know contagious versus active. As long as you have that down, you're gonna be great. And then we'll talk a little bit about biothreats. I don't have too many questions on this. Biothreat agencies, overview and management. We select agents that are high-risk agents that require special handling, and we have to follow, with us in the lab, anytime we get a biothreat, we always have to let the CDC know, we always have to let the state know. Not necessarily something we would do, as long as you let the lab know, we're gonna do our part to make sure it gets reported accurately. All right, we have anthrax, which is Bacillus anthracis, which is a gram-positive rod-shaped bacterium. If you see it, just let us know and let public health know. All right, Yersinia pestis, the plague, gram-negative bacterium. This is endemic in the west and southwest, and the most common biothreat agent is bubonic plague. Bacillus tularemia, fever, chills, dry cough, headache. You'll see that in tick and deer fly bites, contact with sick or dead animals. In chest x-ray, you will look for those respiratory symptoms. So yes, if you spend a lot of time in the field, like I did in the beginning of my military career, you will see that a lot of people end up getting this a lot. Lyme disease as well, ticks. Brucella bacteria, gram-negative bacilli. You cannot diagnose based off of just symptoms. There's gonna be blood cultures, you gotta do a bone marrow, you gotta do CSF cultures. That's all that's saying. Of course, if you see this, let the lab know. Viral hemorrhagic fevers, these are caused by RNA viruses. Okay, these are also transported by animal and insects as well. And again, let us know, let the lab know. See how I'm talking about this, and I'm not gonna test y'all, but I know it'll be recorded. So, monkeypox, WHO epidemiological overview. As of March 7, 2025, 129,523 confirmed cases were in 130 countries. All right, so this is, I know monkeypox was a big thing for a while, right? Like right after COVID, I don't know what happened to it. Have y'all been hearing about it? I haven't heard anything. I know the lab was scared for a minute. We was like, oh, because we thought it was gonna be another like COVID thing, but no, I don't think there was a whole bunch of cases here in the U.S.
I was big in New York.
Was it? Was it at one point? Oh no, you got some. What is that? What is this? What? But anyway, monkeypox. The CDC has their, their collection criteria. When swabbing the lesion firmly 2 to 3 times for DNA recovery, and then you want to place that in the appropriate container and let us know. The lab know. All right, ELOs, we identify TB, HIV, malaria, and viral threats. So remember, I just wanted y'all to know active versus latent TIV, and I want y'all to know the tests that are used for HIV management. And for malaria, I'm not gonna ask you that, and I'm not gonna ask you about viral threats, okay? And that is it for today, okay? Y'all gonna do great. I will see you all, what day? The 18th, right? The 18th, I think. That's it.
Just doing that.
Start about 10 minutes. The site review is optional, so if you don't want to be here, he told me it is completely optional, so you don't